When there is an overwhelming threat to the body, the nervous and endocrine systems produce a well-coordinated, generalized, non-specific response designed to ensure the survival and health of the individual. Your goals for learning are to understand stress in terms of endocrine function, to learn how the nervous system directs a generalized, nonspecific response to stress, to review epinephrine, to review cortisol. Here's what you need to know. The neural input to the hypothalamus, the relationship between the hypothalamus and the autonomic nervous system, the anatomy and function of the hypothalamic pituitary axis. To see definitions of terms, click the bold red words. In this module, we have reviewed hormones that control growth, reproduction, and maintenance of the internal environment. We also have reviewed hormones associated with situations that pose a serious risk or physical or emotional harm to a person. In each instance, the body responds in individual ways to maintain homeostasis and with a coordinated, generalized, nonspecific response called the stress response. Increased blood levels of the hormones epinephrine, norepinephrine, and cortisol are markers that indicate that an individual is experiencing stress. Click Continue to observe stressors. Stressors include prolonged exposure to temperature extremes, heavy exercise, fright, surgery, and emotional stresses, happy or unhappy. The hypothalamus directs the body's stress response. The nervous system sends information about the stressful condition to the hypothalamus, which then engages both the nervous and endocrine systems in response. Click the hypothalamus to begin. The hypothalamus engages the sympathetic nervous system in a neural and endocrine response, the well-known fight or flight response, which prepares the body for immediate physical action. In a combination of direct action by the sympathetic fibers and epinephrine from the adrenal medulla, cardiac output, CO, increases, ventilation increases, blood pressure rises, and is maintained at a level adequate to drive blood to the working organs, and blood flow is redirected from the GI system and other quiescent organs to skeletal muscle and the heart. Sweating is stimulated. Epinephrine reinforces the actions of the sympathetic system, especially relaxation of the airways and dilation of blood vessels to skeletal muscle and the heart. Epinephrine directly stimulates tissues to meet increased metabolic needs. The major effects of epinephrine are stimulation of glycogenolysis in liver and skeletal muscle, gluconeogenesis in the liver, and lipolysis in adipose tissue. Glucose and fatty acids provide fuel for working organs. Notice that this metabolic pattern is similar to the pattern in the post-absorptive state. The activity of the sympathetic system and epinephrine inhibit the release of insulin and stimulate glucagon. Glucagon reinforces the fasting metabolic state, and the active inhibition of insulin is essential to keep plasma glucose levels high. The fast-acting catecholamines initiate the stress response. They produce rapid, short-term changes because they are secreted rapidly from storage vesicles, and they act rapidly on target cells. The effects end quickly when catecholamines are removed. Click the anterior pituitary to continue. The hypothalamus stimulates release of corticotropin-releasing hormone that causes secretion of ACTH and ultimately cortisol for a more prolonged response. Because its synthesis and release are slow and cellular responses require transcription and translation, the effects of cortisol occur after a lag of about 30 minutes. Click the adrenal cortex to continue. Adrenal cortical hormones maintain and amplify the effects of adrenal medullary hormones. Together, the two parts of the adrenal gland act as a functional unit that first initiates and then maintains and modulates the response to stress. Remember that cortisol is a glucocorticoid named for its effects on glucose metabolism. Cortisol mobilizes energy stores and stimulates breakdown of protein, providing amino acids to the liver to produce glucose. The amino acids can also be used to repair damaged tissue. Cortisol acts on the liver to both produce glucose and store it as glycogen. Cortisol stimulates breakdown of triglycerides in adipose tissue that increases fatty acids for fuel and glycerol for producing glucose in the liver. Fuels continue to be made available, glucose for the brain, and fatty acids for other tissues, to ensure survival at a time when an individual may not be able to eat. In the presence of norepinephrine, cortisol enhances the constriction of blood vessels. This is an important contribution to maintaining blood pressure. Cortisol also inhibits inflammation and other aspects of the immune system, keeping it in check. Click the hypothalamic pituitary axis to study additional hormones involved in the stress response. Aldosterone is secreted from the adrenal cortex in response to increased angiotensin. It promotes retention of salt and water to maintain blood volume and blood pressure. Vasopressin, ADH, is secreted from the posterior pituitary. It promotes water retention and, with angiotensin, directs vasoconstriction effects. This response becomes more complicated as combinations of the hormones we have discussed act to reinforce existing effects and add others. Click Continue to see a simplified version of both rapid and prolonged responses. The nervous and endocrine systems maximize gas exchange, mobilize fuel, and maintain the necessary pressure to deliver blood to essential organs. These two systems work together to maintain high levels of oxygen and nutrients in the bloodstream and to ensure their delivery to essential organs. To review what you have already learned about epinephrine and to expand your understanding of it, click an image. Epinephrine binds to receptors on the cell surface. The many different catecholamine receptors activate G proteins that produce second messengers. Cellular responses depend on phosphorylation of proteins. Catecholamines affect nearly every organ in the body. Remember that epinephrine is water-soluble and is transported in the bloodstream as dissolved particles. Because dissolved particles are readily broken down, and because epinephrine is rapidly removed from the bloodstream, it has a short half-life lasting about 10 seconds. The sympathetic nervous system controls secretion of epinephrine. Stress is a major factor that stimulates sympathetic activity. Other factors include exercise, hemorrhage, hypoxia, and hypoglycemia. Epinephrine is synthesized from tyrosine in adrenal medulla cells that are modified sympathetic postganglionic neurons. Epinephrine and norepinephrine are stored intracellularly in storage vesicles. Generalized activation of the sympathetic nervous system causes release of the neurotransmitter norepinephrine from postganglionic sympathetic fibers and release of the hormones epinephrine and small amounts of norepinephrine from the adrenal medulla. Action of the adrenal medulla primarily represents the effects of epinephrine. Epinephrine reinforces the activity of the sympathetic nerve fibers. Because epinephrine reaches all cells of the body through the blood system, it can increase blood levels of glucose and other fuel molecules, and like thyroid hormone, increase metabolic rate. The sympathetic nervous system, including epinephrine, supplies adequate amounts of fuel molecules and oxygen and ensures their delivery to body cells. It is an integral part of the stress response. Epinephrine is taken up by endothelium, heart, liver, and other tissues where it is broken down by enzymes. Breakdown products are excreted in the urine. Pathological changes in the secretory activity of the adrenal medulla are rare. There are no recognized pathologies that cause hyposecretion of the catecholamines from the adrenal medulla. Because the sympathetic nervous system may replace many of the functions of the adrenal catecholamines, an individual can live without the adrenal medulla as long as the sympathetic nervous system is intact and functioning. A rare tumor called a pheochromocytoma, usually found in the adrenal medulla, secretes large amounts of the catecholamines and is not controlled by the sympathetic nervous system. Symptoms associated with a pheochromocytoma may be persistent or intermittent. Episodic symptoms can arise from probing the tumor, standing up or lying down, or abdominal pressure. This patient has a pheochromocytoma and has come to the doctor today because he feels very ill with many of the symptoms of hypersecretion of catecholamines. Based on what you know about the actions of catecholamines, especially epinephrine, choose the symptoms that the patient might have and drag them to the patient's chart. The most prominent feature in patients with a pheochromocytoma is hypertension. Catecholamines act on the cardiovascular system to maximize cardiac output by increasing heart rate and force of contraction. Catecholamines increase total peripheral resistance. Increases in cardiac output and peripheral resistance cause blood pressure to rise. The treatment of choice for a pheochromocytoma is surgical removal of the tumor. Secretion of catecholamine hormones then returns to normal and is again under the control of the sympathetic nervous system. To review what you have already learned about cortisol and to expand your understanding of it, click an image. Cortisol enters cells by diffusion. Nearly every cell in the body has receptors for the glucocorticoids. Cortisol binds to receptors in cytosol and the nucleus that alter gene expression. In addition to intracellular receptors, there are plasma membrane receptors for cortisol. Rapid inhibition of CRH by the feedback loop is mediated through these plasma membrane receptors. Remember that the steroid hormones are lipid-soluble and therefore bind to carrier proteins for transport through the circulatory system. The bound hormone exists in dynamic equilibrium with unbound or free hormone in the plasma. Only the free hormone is available to leave the bloodstream and act on target cells. Because cortisol is bound to carrier proteins, it has a relatively long half-life, lasting about 90 minutes. ACTH, or corticotropin, controls secretion of cortisol and promotes the growth of the inner zones of the adrenal cortex. Corticotropin-releasing hormone stimulates secretion of ACTH. Negative feedback from cortisol inhibits the secretion of both ACTH and corticotropin-releasing hormone. Despite the negative feedback system, blood levels of ACTH and cortisol vary in a circadian rhythm. This daily variability results from the changing sensitivity of the CRH-secreting cells to cortisol. The circadian rhythm may allow the nervous and endocrine systems to anticipate the need for cortisol that is associated with daily activity. Stressors like pain, fear, physical trauma, infection, prolonged cold, or emotional problems elicit secretion of CRH. Other hormones associated with stress, such as vasopressin, ADH, increase cortisol levels. Cortisol is synthesized from cholesterol in adrenal cortex cells. The cells do not store cortisol. Cortisol is important in the body's response to stress. It is key among the many hormones involved in controlling metabolic fuels. It ensures an adequate supply of glucose and fatty acids during times of stress when a person has not eaten. It decreases glucose use in muscle and adipose tissue and spares glucose for the brain. In the absence of cortisol, a short fast can produce dangerously low plasma glucose levels and glycogen depletion from skeletal muscle and the liver. Cortisol acts on blood vessels to enhance the effects of sympathetic vasoconstriction. In the absence of cortisol, a moderate stress can produce hypotension. Cortisol has protective effects that are not well understood. Without an adequate rise in cortisol, a person can die from a severe stress. Death usually results from the failure of the circulatory system. Cortisol inhibits inflammation and depresses the immune response. Too great an inflammatory response can harm nearby healthy tissue, and too vigorous an immune response may cause harm potentially leading to autoimmunity. Cortisol acts to temper these important body defenses. This action of cortisol is exploited by the pharmaceutical industry for the treatment of rashes, asthma, other inflammations, and autoimmune diseases. Recall that cortisol is a steroid hormone. Humans cannot break down the steroid nucleus. Its inactivation depends on altering the molecule and excreting it in the urine. One way that scientists learn about the endocrine system is to observe the symptoms of patients who secrete too much or too little of a particular hormone. Two relatively rare diseases of the adrenal gland help illustrate some of the functions of cortisol. Cushing's disease, or hypercortisolism, occurs when the body is exposed to high levels of cortisol for a prolonged period. Addison's disease, or primary adrenal insufficiency, occurs when the adrenal glands produce too little cortisol and too little aldosterone. Cushing's disease is caused by tumors of the pituitary that secrete increased amounts of ACTH. It is the most common cause of hypercortisolism. Hypercortisolism from all other causes, such as glucocorticoid drugs, is called Cushing's syndrome. The glucocorticoid prednisone may be prescribed for asthma, rheumatoid arthritis, other inflammatory diseases, or for immunosuppression following an organ transplant. Addison's disease is caused by damage to the adrenal cortex, inducing hyposecretion of both cortisol and aldosterone. Hyposecretion of cortisol from other causes, such as pituitary damage and subsequent lack of ACTH, produces similar symptoms. In this case, aldosterone secretion is normal. Cushing's patients experience paradoxical accumulation of fat that produces a round moon face and a buffalo hump on the back. A cardinal symptom of Addison's disease is a change in skin pigmentation that produces a bronzed color. Based on what you have learned about cortisol, answer the following questions. Click on the patient who will have the symptoms described. You must get the correct answer to proceed. Which patient has hypoglycemia? One function of cortisol is to promote production and release of glucose. Lack of cortisol results in low plasma glucose. Which patient may exhibit signs of steroid diabetes? Hyperglycemia in Cushing's patients can lead to diabetes mellitus. The chronic increase in insulin levels induced by hyperglycemia can cause pancreatic beta cells to fail. These high levels of insulin might also explain the redistribution of body fat. The action of insulin on normal body fat stores is antagonized by cortisol. In other body areas, like the face and upper back, insulin can promote lipogenesis. Which patient might get dizzy or faint due to low blood pressure? Cortisol promotes vasoconstriction. Insufficient amounts of cortisol can lead to dangerous low blood pressure. Both patients may feel fatigued and have muscle weakness, but which one will have increased nitrogen breakdown products in the blood and spindly arms and legs due to muscle loss? Cortisol promotes protein breakdown to supply amino acids to the liver where they are used to produce glucose. Loss of protein also accounts for the easy bruising and poor wound healing seen in Cushing's patients. Which patient may be at risk for overwhelming infections? Cortisol inhibits the inflammatory response and depresses the immune system. The risk of infection rises in patients who are taking prednisone and those with hypersecretion of cortisol. Which patient may show decreased plasma levels of sodium and dehydration and therefore crave salty food? Loss of aldosterone accompanies the loss of cortisol in Addison's disease. Aldosterone acts to retain salt and water. Note that the loss of aldosterone contributes to the low blood pressure in Addison's patients. Both of these pathologies can be treated. Cushing's disease is treated by surgical removal of the tumor. When Cushing's syndrome is caused by therapeutic drugs such as prednisone, treatment involves adjusting the dosage of the drug. Addison's disease is treated by replacement of cortisol and aldosterone. Secondary adrenal insufficiency is treated by replacement of cortisol. Here's a summary of what we've covered. The stress response is mediated at first by the sympathetic nervous system and epinephrine, and later by cortisol. The response to stress is designed to protect the body from harm and ensures survival. A tumor called a pheochromocytoma causes hypersecretion of epinephrine. Hypersecretion of cortisol causes Cushing's syndrome, whereas Addison's disease is hyposecretion of both cortisol and aldosterone. To test your knowledge, click the quiz button to go to the self-quiz. To access cross-references for this topic in your Benjamin Cummings textbook, click here. To test your knowledge, click the quiz button to go to the self-quiz.